Hello everybody, welcome back to another amazing video on STEMI. So here I've got you a 64-year-old male who's an ex-smoker with a history of type 2 diabetes mellitus and systemic hypertension for more than 17 years, presented with acute central chest pain with profuse sweating since 2 hours. So sweating is less than, less than 2 hours. On examination, pulse rate is high, BP is high, JVP is 2 centimeter above the clavicle, serious heart sounds are muffled, respiratory few crackles in the lung bases. Now, what is the probable diagnosis? So, this is our question. So, they have told age, which is high, smoker, which is a risk factor, diabetes, risk factor, hypertension, risk factor, and the chest pain is central and acute. And they have profuse sweating since 2 hours. So, what do you all guess? Yes, it is STEMI. It's acute ST-Elevation Myocardial Infarction with evolving cardiogenic pulmonary congestion. So, this is our most probable diagnosis, and this is the topic for today. STEMI. Yes. Now, coming to the definition, acute STEMI is a myocardial necrosis, the death of the myocardial tissue due to acute complete thrombotic occlusion of the coronary artery, producing ischemic symptoms, ST segment elevation in more than or equal to two contiguous leads. So I've taken the ECG class in which I have mentioned about all the STEMIs, all the important ones, how to decode a ECG in just 5 minutes, everything I've mentioned in that. And elevated cardiobiomarkers. Now, ST elevation criteria is more than or equal to 1 millimeter in limb leads, more than or equal to 2 in men less than 40 years, more than or equal to 2 in men more than 40 years, and more than or equal to 1.5 mm in women in V2 and V3, and more than 1 mm in other precordial leads. So as you can see that this is a partial occlusion and this is a total occlusion. So as I have told you that STEMI is a complete occlusion. It's a complete occlusion of the coronary artery. So the coronary arteries are completely occluded. Moving on, this is ST elevation in 2 or more consecutive leads. So you can see that here is a ST elevation. And then if you see, there's again an ST elevation. There's an ST elevation. So in everything, you can see an ST elevation. So here, you can clearly see there's an ST elevation. In these two, you have two consecutive or contiguous ST lead elevation. Now moving on to the etiology, you have atherosclerotic plague, which plague rupture, and which is the thrombus formation is the most common. And sequence, you have vulnerable plague and the plague gets ruptured and tissue factor exposure leading to platelet plug, then fibrin rich occlusive thrombus, and other less common causes. You have 5 of them, which is coronary embolism, coronary spasm, spontaneous coronary artery dissection, vasculitis, and trauma. Obviously, trauma is one of the causes for most of the causes. And as you can see, this is a vulnerable plague. And this is a stable plague. You know, the lipid layer is different in vulnerable and in the stable plague. The lipid layer is thin in vulnerable, whereas it's in stable, it is thick. Moving on to the pathophysiology, it is of 2 types. One is events after acute coronary occlusion. One more is structural changes. Now, what happens in 1 to 2 minutes is the aerobic respiration changes into anaerobic respiration. That is, the metabolism changes from aerobic to anaerobic. Then, in 2 to 20 minutes, you have a reversible tissue injury. Now, the tissue injury becomes reversible. In 20 to 40 minutes, irreversible myocyte necrosis happens. There's necrosis of the cardiac tissue. It begins here. It's the stage of the beginning. Next, in 3 to 6 hours, there is the transmural extension of the infarct. So there's already an infarct. It is going transmural, means to all the layers. So as the time progresses, the infarct also covers all the layers of the tissues. Then in 6 to 12 hours, there's complete transmural necrosis. The infarct changes into necrosis. Now, this is the summary. In 0 to 2 minutes, aerobic respiration to anaerobic metabolism, then reversible injury, and then irreversible myocyte necrosis, then transmural extension of the infarct, and the infarct changes into necrosis if left untreated. Now, wavefront phenomenon of cell death is a golden point for you all to remember. Now, coming to structural changes, what happens in 0 to 24 hours? Coagulative. We know that in second year pathology, we study that heart undergoes coagulative necrosis, and same thing happens here. Next, in 1 to 3 days, you have something called as neutrophils. What are the neutrophils happening? Neutrophil infiltration. There's neutrophil infiltration. Moving on, macrophages. Here, there is macrophages coming up that causes rupture. So this tissues are getting ruptured. Now this is the granulation tissue formation. Then you have collagen deposition in more than 2 weeks, and finally when it becomes more than 2 months, what you have here is a dense scar. Now, this is the summary of the structural changes: coagulative necrosis, neutrophil infiltration, macrophage infiltration, granulation tissue, collagen deposition, ending with a dense scar. Moving on to the risk factors, you have modifiable and non-modifiable. Among the modifiable, you have diabetes, hypertension, smoking, obesity, and dyslipidemia. In non-modifiable, you have age, male sex, so sex male is predominant, and family history of STEMI. You have a golden point which I want you to know. That is nothing but about the KILIP. So it is the KILIP class. More than one on presentation increases the mortality. So this is a viva question you have to remember. Now moving on to the symptoms. So what is this? So this is classically a prolonged, severe, crushing chest pain for more than 20 minutes, which is radiating. There is radiation of the pain. It is radiating to the left arm, jaw, and to the epigastrium. And it is associated with other common symptoms like nausea, vomiting, dyspnea, panic attack, all of that. Moving on to the signs, you either have a tachy or a bradycardia, then you have a hyper or a hypotension, and then you have something called as S3 gallop, which is nothing but LV dysfunction. You get a sound like that when you auscultate, you get a sound like that. And here you see papillary muscle dysfunction, and this one is crepitations. So it's in the chest, so it is pulmonary crepitation. So these are the signs. You have hyper or hypotension, you have tachy or bradycardia, you have papillary muscle dysfunction, and you have pulmonary crepitations and S3 gallop or LV dysfunction. Now this covers the STEMI's definition, etiology, pathogenesis, risk factors, symptoms and signs. Now go back, rewatch, take a screenshot and make your STEMI prep a 10 on 10. For ECG changes, localization, cardiobiomarkers, diagnosis and management of STEMI, stay tuned for part 2. Thank you so much.